Welcome to today's Research America Alliance discussion. I'm Dr. Scott Zeger, your moderator. For the next several weeks, Research America will be hosting Alliance discussions featuring some of its 2025 advocacy awardees. I'm looking forward to the first discussion today. Thank you for joining us and for your partnership in the Research America Alliance. Today's special guest is Dr. Al Sommer, recipient of Research America's 2025 Outstanding Achievement in Public Health Award, generously supported by Johnson & Johnson. Dr. Sommer has been a tireless advocate for improving public health by promoting the adoption of medical discoveries into clinical medicine and public health practice. He is currently the Dean Emeritus and University Distinguished Service Professor at Johns Hopkins University, Bloomberg School of Public Health. Dr. Sommer will share insights from his storied career, from his life-saving work as a clinician, making the connection between vitamin A deficiency and childhood mortality, to his leadership as the Dean of the Bloomberg School for over a decade. Before we get started, I'll quickly remind our audience to please type your questions into the Q&A box or chat, and we'll pose as many of them as we can during the Q&A portion of today's discussion. Thank you for joining us today, Dr. Sommer. It's an honor to have you with us.
Oh, and it's an honor to be here, Scott.
Let's get right to the questions. You were originally trained as an ophthalmologist. What kindled your interests in numbers, epidemiology, and international health?
Well, in fact, before I became an ophthalmologist, during the Vietnam era, I was seconded to Center for Disease Control as an EIS, Epidemic Intelligence Service officer. Not that I knew anything about epidemiology at the time. And I and my family went overseas to what was then East Pakistan, now Bangladesh, to the Cholera Research Laboratory. So I was sent there to basically study cholera and the impact of new vaccines that were becoming available, none of which actually worked. And while there, I found that there were a number of questions. Just the ground was full of these golden bricks, interesting questions that could be answered relatively straightforward simply by counting and adding it up and dividing and what else that you do. And so when I returned to the States, I enrolled first. I postponed my residency to get a degree in epidemiology at what is now the Bloomberg School of Public Health. And then I began my residency for 3 years, during which I actually did some epidemiologic studies. And then in 1976, went with my family overseas to Indonesia to continue with work.
Great. Thank you. So let's go to soon thereafter, 1986, and you reported a blockbuster finding that vitamin A supplementation, 2 capsules per year at a cost of about 2 cents per child, reduced child mortality in Indonesia by 40%. Were you surprised?
Well, first, I was totally surprised because I wasn't answering that question. That was not, the particular study was not set up to address that question. It was set up to address the question of what's different about children who develop vitamin A deficiency and children who don't. But it turned out the design of the study was such that how many children died, whether or not they got vitamin A in this study, just dropped out with this huge potential impact. So I was very surprised. And while we published the data, you're right, many people in the field, people who really were nutritionists, which I wasn't, or really were pediatricians, which I wasn't, or child survival, which I wasn't, absolutely disagreed, could not believe that a 2-cent pill of vitamin A would in fact have this kind of impact. In fact, some people at our own institution were published saying that, you know, if Al had said it was 3% impact, maybe we believe it. But 30 to 40% impact, that's ridiculous. And one person was quoted as saying, if it was that big, we would have known it already.
Al, could you make the connection for people a little bit more about vision and mortality? How does vitamin A how did an ophthalmologist find that vitamin A
That's
was
a
related to
that's a
mortality?
very good question, because the one thing that people knew about vitamin A at the time, and every ophthalmologist certainly did, was that if a child gets sufficiently vitamin A deficient, then their cornea becomes involved, melts away, and they can lose their vision entirely in one eye or in both eyes. And so I was studying it as an ophthalmologist from an ophthalmic perspective to see why did some children go blind and some children didn't, and why did some have vitamin A deficiency and others didn't.
Amazing. So let me just then take you to the next step. You discover that there's 40% reduction in mortality among these children, and it wasn't just in Indonesia, it was discovered, similar patterns were discovered elsewhere. And over time, you worked on trying to make vitamin A supplementation standard practice in Asia and Africa the way it was in the United States. What was involved in that effort?
Well, the first which was the most difficult to get over, were all these experts, quote unquote, in the field, vitamin A, child survival, who absolutely didn't believe this. So it was doing study after study. We did study after study. Others did studies to at least come to a conclusion that, yes, this was real, and it was real in more than one population. Indonesia was real in Nepal. It was real in India, and it just, so we accumulated the evidence, although that didn't stop a large number of experts in the field from disagreeing. But finally, when I thought we had enough evidence on our side, I couldn't do any more studies. It would be unethical. That I organized a meeting at the Rockefeller Study Center in Bellagio, Italy, which I brought people who are experts in various parts of this, from nutrition, from immunology, from infectious disease, pediatrics. And we spent a whole week going over all the data to answer basically two questions. One, does giving vitamin A to children who are deficient reduce mortality? And secondly, the other thing that had popped out was very specifically, it dramatically reduced mortality from measles, which is a big problem in the developing world. And at the end of the week, on Friday morning, I felt that we, in fact, had come to a consensus. That doesn't mean that everybody else, that there weren't people on the outside who still disagreed, but at least the people in the room, who were all experts in the area, did agree. So I typed up a thing that said, we all agree with the following, and everybody signed it in blood. And then I asked the people who were present that if they could, when they went back home, because they were from around the world, if they would publish their perspectives from that meeting in their local medical journal. I did it in Lancet, somebody else did it in the Medical Journal of South Africa, and so forth. So that at the same sort of time, all of these, quote, experts in the field were able to express support for this this relationship between vitamin A status and childhood mortality. And then very quickly after that, Jim Grant, who was then the Secretary General of UNICEF, and Nakajima, who was then the Director General of WHO, both came together, saw this as a fabulously inexpensive way to reduce child mortality, and had a big celebratory meeting, and then launched the global program.
And can you tell us a little bit more about the global program? Where is vitamin A supplementation used? Are there some parts of the world where they don't do this?
There are, a lot of this is politics, a lot of this is funding and what have you. Canada initially was the long-term supporter of the program that went through UNICEF, organized by UNICEF, but clearly a lot of the money had to come from the country itself. And most countries in the developing world, there are 40 some odd countries who have active programs where children get 2 cents worth of vitamin A twice a year. That's a standard program. There are some countries where they don't do it for a variety of reasons, cost being one, organization being another, but most of the countries at least propose that they do it.
Great, thank you. Now, let me take you to the next part of your career. So in 1991, you became the dean of what is now called the Johns Hopkins Bloomberg School of Public Health. And you're famous for many things in that role, but I want to take you to that moment when you created a now famous tagline protecting health, saving lives, millions at a time. What were you trying to achieve with that tagline?
Well, when I came in to be, I mean, I remember some of the trustees at Hopkins, I heard them say to one another, an ophthalmologist is dean of the School of Public Health. Couldn't we do better than that? So it was an interesting convergence where I was asked to take on that job. And at the time, thought it's not what I particularly wanted to do, but subsequently enjoyed doing it. That line was because I became in that position starkly aware of the fact that public health was basically unnoticed, unrecognized, and unrewarded. And as I said to a number of the people, including Mr. Bloomberg at the time, Mayor Bloomberg at the time, was that if somebody has a crushing chest pain and they go into the emergency ward and they're saved from their heart attack, or they have pneumonia and they're saved from life-threatening respiratory infection, they love their doctor. I mean, the doctor has saved their lives. He or she are, wonder people. Of course, if public health is successful, absolutely nothing happens. So nobody is grateful to public health because it didn't appear that they did anything. The fact is that people live longer, that vaccines basically eradicated measles in the United States and so forth. That's not apparent. So they're not generous to support schools of public health. And the public health community itself is very poorly supported by the state, city, and national government. So it was a way to try and get people to better understand the impact that public health had, despite the fact that they didn't see some dramatic clinical recovery as part of that.
And I just maybe like to ask as a follow-up, how did this tagline get received by some of the other deans in the university?
Well, maybe I was being too grabble at the time, but at the first meeting I went to shortly after we had this, with all the deans, the person who was running that meeting said, Al, that is a great line. We're adopting that for our association. Too bad you didn't copyright it. And I had to say, it is copyrighted. So, but I've been very generous and I'm happy for others to use it, but they have to recognize that it's copyrighted.
And I wonder if you might just spend a moment reminiscing a little bit about some of the opportunities you had as dean. Are there any moments in your deanship that particularly stand out in your memory?
Well, one was appointing you as the deputy dean. That was a terrific savior of my life, and I could exist because I couldn't do everything myself. That was for sure. I think a couple of things that we did is you come into a system, you try to understand the bureaucracy and how everything is operating. And it was clear, for example, as a minor thing, that the Department of Biostatistics was being not fairly treated in terms of the financial formulas. And so we got a long discussion and got all the other chairs to agree that we could change the formula, which has gone by the name of the Zeger formula. So, we all recognize the important role that you played in that. And other things was trying very hard to bring this importance of public health attention to the wider community through editorials and talks and papers that I wrote and supporting the faculty better than we did.
Great, thank you. So I want to just ask a follow-up question. If you could imagine yourself back when you returned to the Wilmer Institute, having worked overseas for a while, and you embarked on a career that took you to clinical medicine, but also around the world on public health research programs. What would you say to somebody who's today the age that you were then, thinking about careers in medicine and public health, perhaps at the interface like you did? Any thoughts you want to share with somebody in that circumstance?
Well, today is a little difficult, as we all know, given the new administration, but we'll ignore that for the time being and think of what it would have been like a month ago. And I would say, and I say it because many young ophthalmologists, many more than when I was interested, of course, because there were very few interested in those days, are interested in doing global ophthalmology and doing sort of combining public health and ophthalmology. So we had started a training program in exactly that, in global ophthalmology for the prevention of blinding diseases, and had a number of people who got a master's degree at the school before I became dean. But since then, and whenever we'd have a meeting overseas or an international blindness prevention meeting or something like that, it would be within the context of a large ophthalmology meeting. And these people who did this with me, often from the developing world, we'd go into the conference hall and there'd be 3 people in the audience. And next door, there were 4,000 people in to learn the latest surgery on cataract. And I remember them saying, why are we bothering to do this? Well, now that's not the case. I mean, I go to the American Academy of Ophthalmology meetings, and when you're there, you see a room of 300 people to discuss prevention of blindness around the world. So I think it's doable. You got to be supported in part, finding the funding, and an institution that will accept and glorify this is an important role, but many more are doing that than were doing it when I was first starting out.
Great. And I wondered, we certainly can see how your training in medicine and ophthalmology in particular made you uniquely qualified to discover this vision effect of vitamin A, which then led you on to find mortality effects of vitamin A deficiency. So that's sort of your medical training being informative of your role as an international health researcher. I wonder, how about in the other direction? I wonder if all of your experience in international health, epidemiology, biostatistics, how do you think that's impacted your clinical understanding, your clinical work?
Yeah. Well, first of all, let me just characterize. I did not discover the relationship between vision and vitamin A. That was long known. Well, I'll give you an example about how it both impacted me and others. So when I came back to the States and started to get involved going to the American Academy of Ophthalmology annual meetings, I discovered that one of their principal advertising points was that every American should get an annual eye exam. And that struck me as really odd and a terrible waste of time, because most people, other than being okay when you're an infant and maybe needing glasses when you're when you're a child, you don't get any serious eye diseases until much later in life. So I actually did a little calculation on the back of an envelope. And if we actually gave every American an annual eye exam, there'd be no time for ophthalmologists to do anything else. They couldn't take care of glaucoma. They couldn't fix a retina. They couldn't do cataract surgery. And so I brought this to the attention of the leadership of the Academy, and to give them credit, they said, oh my gosh, we shouldn't say that anymore. And by the way, let's establish a quality of care committee, and you'll do it, Al. And so that was a preferred practice patterns. Is still being issued regularly for 25 different eye diseases every year. And they were one of the first clinical guidelines that were established in any medical subspecialty. So, in that way, we've changed that. 40 years later, we still have updated guidelines on what's appropriate and acceptable practice in treating diseases in the ophthalmologist's office.
Right. So, Al, I only have one more question. As you know, I'm a statistician by training, and one day I was reading in the leading journal in my field that it was a review of all the books written about statistics, which is not a very exciting topic, written by various people in the medical field or in economics and places like that. And this article was ranking all of the statistics books written by non-statisticians in all the different fields. And lo and behold, there you were. Al Sommer had written a book entitled Epidemiology and Biostatistics for Ophthalmologists. And I looked it up just now, and I see that it's selling in paperback for $108.21 at your favorite online bookseller. So I want to know, what motivated you to write a book in biostatistics when you were busy saving vision and saving lives millions at a time?
Well, that's a wonderful story, and I hope we have time for me to go through it. When I was a first-year resident, the chairman at Wilmer, Ed Malmedy, who was a giant in ophthalmology, One day he said that I should read a particular paper in the American Journal of Ophthalmology, and it was a fabulous study. And I read the paper, and it was a terrible study. And so I explained to him it was a really terrible study, and that's why it violated all these epidemiologic principles. And he said, because he was a very encouraging teacher and mentor, he said, well, Al, you ought to write an editorial on that. And I'm thinking, you know, I'm a first-year resident. I'm up every other night. I don't think I'm going to write an editorial on this. So this shows how brilliant Ed Baumann was. So when I told him I wasn't going to write it, he didn't say anything. 3 days later, I received a letter from the editor of the American Journal of Ophthalmology saying, "Dear Dr. Sommer, Dr. Baumann has told me about this brilliant editorial you have written. We look forward to receiving it within the week." So I had to write a brilliant editorial, and that got me to the point, well, there's no reason why ophthalmologists would know epidemiology and biostatistics, so I have to write a book for them. A nice, simple book, short, and all the examples are ophthalmic, so don't worry. The problem was when I went to get it published, I went to the usual publishing houses for medical textbooks. They said, "Oh, we love this, but it can't just be ophthalmology. We want some obstetrics and some pediatrics and trauma." I said, if I do that, then the ophthalmologists aren't going to read it. And so I said, no, we're not going to do that. And Oxford Press came along and said they'd be happy to publish a book that was basically aimed at ophthalmologists.
Well, excellent. Well, thanks. This has been a wonderful conversation so far. So now let's see what audience questions we have. Jacqueline, could you join us?
Yes, thank you, Dr. Zeger, and thank you, Dr. Sommer, for this great discussion so far. And it's been great to learn about your career in public health. So our first question from the audience, given the current world, how do we better make the case for public health and disease prevention?
Sorry, say that again, given the current world.
Given the current world, how do we better make the case for public health and disease prevention?
You know, again, the last 2 weeks have made everything problematic, and nobody I think knows the answer to that. And those who are leading public health have tried very hard to make the case. And while it seems to us that it's easy to make the case, you know, nobody's getting polio anymore, and nobody's getting measles anymore. Well, that might all change if we stop giving childhood vaccinations. I think you just have to keep pressing on and making the point, saving lives millions at a time.
All right. Thank you. I agree. So for our next question, it's sort of related, but if you can elaborate a bit more, how should today's increased skepticism regarding vaccine effectiveness best be addressed?
Oh my gosh, there are people who've been working on this for years. I'm no expert in that, but literally for years. In fact, at one point, I remember learning that this goes back about 10 or 15 years, that the least vaccinated population in the United States lived on Vashon Island. Now, where is Vashon Island? It's an island right off the coast of Seattle. Who lives there? All the Microsoft engineers. So here you have highly educated people, highly intelligent people, and they had this fear of vaccination. And none of us have found a magic answer. You know, of course, and now we have somebody who may be appointed to direct everything in national healthcare and research who doesn't believe in vaccination. So it's a real problem. I think we're going to absolutely need a political change before that happens. And then we have to keep working on the public. But there have been a large group of the public who just, particularly now, simply don't believe in science.
Yeah, thank you. It's a tough environment for sure. So a follow-up question, this is relating to your career. With so much skepticism in your initial studies, how did you convince agencies to fund your follow-up trials and studies? And to thank you for being a hero of public health.
Yeah, that's a very good question. And the person who was then head of nutrition at AID loved the work. If it were not for him, I'm sure none of this would have been undertaken, and we would, you know, be losing a lot more children than we're losing now. But it was Marty Foreman, who was a longtime director of nutrition within USAID, which may not be around either any longer, who followed this vitamin A thing ever since that early meeting that I went to and discovered that people didn't believe in any new things other than what they'd known in the past. And he just followed it and helped paid to form a vitamin A interest group, which was international in scope, which I led for a number of years, and funded to have all these studies, which closed the question. And he stuck with it. And without his funding, it would have been very difficult.
Great. Great. He was the right place at the right time. We have another question from Dr. Zeger. Are there some new areas of public health that you think need more attention that are currently being given, for example, global warming?
Well, global warming is going to affect everything, public health and nutrition, and it's the fires in the West Coast and floods in North Carolina. It's gotten a lot of attention by people who understand science and are the people who you think who are actually being affected by the weather change. How much more we have to do in order to get people to, they're sort of like saying it's not worth investing because I can make more money doing what I'm doing regardless of whether the planet gets hotter and weather patterns change dramatically. Then you think, well, have you been thinking about your grandchildren or your great-grandchildren? What are they going to inherit, if anything? I don't know how we go about doing it. We just have this unbelievable split in our population now, where some are willing to accept data and some are unwilling to accept data. They like beliefs more than they like data.
Well, I believe I have only time for one last question before I turn it back over. Can you relate the success of the treatment for, I hope I'm saying this correctly,
Onchocerciasis.
Thank you.
River blindness would be easier.
River blindness, and how that might inform current endeavors or be problematic in that regard.
Well, that was a great triumph. It cost a lot of money, but the disease that is mentioned is caused by a black fly, which injects a worm basically into you without you knowing, just by a little bite. Not very different than a mosquito bite. And then this thing grows within the body and it gets quite large, and there'll be multiple ones, and they send off little organisms which then invade the eye and then cause blindness. So it was a very major cause of blindness in much of Africa. And the first major elimination of onchocerciasis was a dedicated program through the World Bank. And they've said a fortune, in which it was spilling, there were low-flying aircraft that were dumping insecticides into the fast-flowing rivers. And that killed the larvae because that's where they reproduced. So that was the first big impact. After that, the second big impact was the discovery by a Merck scientist that one of the drugs they had and they used for worms in dogs actually worked on curing people who had this worm infestation. Muhammad Aziz was his name. He was originally from Bengal. And then was trained in the UK and then became a leading scientist at Merck. And he convinced Merck that this was important. He was very clever the way he convinced them. He published his paper, his original 40 patients, in the New York Times. So everybody saw what this result was. And then Merck made this unbelievable commitment that was, we will make this available to all who need it for as long as they need it. And they're still sticking by that principle, and they've gotten many awards and recognition for doing that.
Thank you. Thank you, Al. It looks like we've used up our time. So Al, thank you very much for joining us, and congratulations on your award. We look forward to honoring you in person at the awards ceremony on March 12th. One quick announcement before we end today's meeting. Please join us for the next discussion on February 18th at 10:30 to 11:30 Eastern with two experts in this area, Dr. Chiri Kaplagat, a lecturer at the Department of Epidemiology and Medical Statistics at Moy University School of Public Health and a researcher at Empath in Kenya, and Dr. Rosemary Morgan, a colleague of ours, an associate research professor at Johns Hopkins Bloomberg School in the Department of International Health. They'll discuss research on aging in low and middle income countries and how it relates to aging in the United States and the need for stronger global research on aging. Thanks again for joining today's Alliance discussion. We look forward to seeing you next time.